Our final presenter of the day is Dr. Allison Applebaum. She is a caregiving scientist, writer, researcher, speaker, and advocate. She is a professor of geriatrics and palliative medicine and the director of the Stephen S. Elbaum Family Center for Caregiving at the Icahn School of Medicine at Mount Sinai. She was previously the founding director of the Caregivers Clinic at Memorial Sloan Kettering Cancer Center, the first program of its kind in the United States to provide comprehensive psychosocial care to family members and friends of patients who are in the caregiving role. Dr. Applebaum's program of research focuses on the development and dissemination of supportive services for family caregivers. She's published over 100 articles, reviews, and book chapters on these topics, and is the editor of the textbook Cancer Caregivers. Dr. Applebaum has received competitive funding for her research, including awards from the National Cancer Institute, the National Institute of Nursing Research, and the American Cancer Society. She is also the author of the recently published narrative nonfiction book, Stand By Me, A Guide to Navigating Modern Meaningful Caregiving. Thank you so much for being here.
Thank you so much, and hope it's been a good afternoon for everyone. Today I'm going to be speaking about the work that I've done to date for the past 15 years before coming to Mount Sinai last year in supporting family caregivers of patients with cancer. But everything that I'm speaking about, all of the skills, all the tools, all the approaches are appropriate for caregivers of patients living with any type of chronic or life-limiting illness, disability, or mental health challenge. Just want to acknowledge my disclosures, which are unrelated to today's presentation. And I always like to ground my talks in the words of former First Lady Rosalind Carter. She was an incredible advocate for family caregivers, and she devoted her public service to addressing the mental health needs of family caregivers. And she's very famous for saying that there are only four kinds of people in this world: those who've been caregivers, those who are caregivers, those who will be caregivers, and those who will need caregivers. This means that this is a role that touches all of us. It's a role that we enter and we exit repeatedly throughout our lives. It's one that deeply changes who we are and the trajectory for our life moving forward. So in answering the question, what do caregivers do? The simple answer is they do absolutely everything. Caregivers provide support with activities of daily living as well as instrumental activities of daily living. They help with medical and nursing tasks, and too frequently, they do so without training, education, or support, and this is something I'm going to be turning back to. Caregivers provide emotional support to patients, and importantly, this is often at the same moment when they're no longer receiving the same level of emotional support that they once received. And so there is a mismatch in the support received in terms of emotional support. In terms of care, on average, caregivers provide care for 5.5 years. 29% are more than 5 years, but I should say 10% of U.S. caregivers are in the role for a decade or longer, meaning that this is an ultra marathon of caregiving for a good number of caregivers. And on average, caregivers provide care for 23.7 hours a week, but nearly 1/4 of caregivers provide care for over 40 hours, meaning this is a full-time job, often conducted in addition to full-time paid employment. In 2023, the annual economic value of caregiving was estimated to be $600 billion. That is the value of all of the efforts of caregivers accounted for $600 billion, despite the fact that a good number of caregivers report high financial strain and up to 20% actually go into poverty as a result of caregiving. And so there's a very significant disconnect between the financial toxicity experienced by caregivers and the value of their efforts. And for many years, I've been saying that caregivers are critical to our healthcare system. In many ways, they are the invisible backbone of the U.S. healthcare system. Every 5 years, the National Alliance for Caregiving conducts studies where they evaluate the state of U.S. caregivers. Their 2025 data came out in July. And what I want to highlight for you is the fact that the number of caregivers has increased by 10 million from 2020 up to 63 million. And we anticipate this number is only going to continue to grow rapidly. Based on the 2015 report, so over a decade ago, they did a sub-study on U.S. cancer caregivers. And the reason why I'm sharing this is to highlight the title of this sub-study: Cancer Caregiving in the United States, an Intense, Episodic, and Challenging Care Experience. And that is because the cancer caregiving experience uniquely is often very short and very intense. On average, cancer caregivers are in the role for 1.9 years versus on average 4.1 years for everyone else. Caregivers, not surprisingly, are predominantly women, and on average, they are 50.6 years old. But I want to draw everyone's attention to the growing number of caregivers who are between the ages of 18 and 34. These are adolescent young adult caregivers for whom caregiving responsibilities place significant impediments to development in the areas of education and employment and social relationships and family building. And the 2025 report said dramatically there is a notable increase in the number of children, of minors who are serving as caregivers. In fact, 13% of patients in the United States today say that a child is taking care of them. So this, too, is a group that's really going to need our support. In terms of relationships between caregivers and care recipients or care partners or patients, we can call them all three of those things. Most commonly, caregivers are taking care of a relative and most frequently a parent or parent-in-law. And in terms of that care recipient's medical condition or illness, most prominently, it's old age or dementia, cancer you can see down there. There's lots of other reasons listed, of course. As I said, caregivers help with everything, all ADLs, all IADLs. But I actually really want to draw your attention to the fact that 65% of caregivers in the United States, which is an increase from 2020, 65% are helping patients to navigate incontinence. And the reason why I share this is that these care tasks are ones that are physically and emotionally and socially and spiritually and existentially very, very challenging. And importantly, 55% of caregivers perform medical and nursing tasks, too often without training, education, or support. In terms of working while caregiving, 70% of caregivers do engage in paid employment, but nonetheless, a very significant portion, 18%, report very high financial strain. And in terms of caregivers' own self-rated health, 21% report their health as fair or poor. And I want to say this is the exact same percentage as was indicated in the 2020 report. There's been no change, which is a problem. We are not doing a good enough job to support caregivers. To build on that argument, 23% find that it is difficult for them to care for their own health, and 38% report high emotional stress. 24% of caregivers in the United States report feeling alone. Isolation is one of the most critical challenges faced by caregivers. Certainly, this was exacerbated in the setting of the COVID-19 pandemic, but it remains a challenge for all caregivers, especially those who are taking care of immunocompromised loved ones. And yet at the same time, I want to share from the report, 51% of caregivers said their caregiving role gave them a sense of purpose. And this is something I'm going to turn back to later today. The majority of caregivers experience what is called caregiver burden. In fact, almost every parent, partner, child, sibling, friend with whom you come into contact in your clinical practice, at the bedside, in the waiting room, outpatient, over Zoom, every caregiver at some point is going to experience caregiver burden. This is a catch-all phrase that refers to all the ways in which the caregiving role can potentially negatively impact the caregiver. The first component is psychological. One of the most important statements I'm going to say to you today, we know that diagnostic rates of anxiety, depression, and even post-traumatic stress disorder are higher in family caregivers than the patients for whom they provide care. And that is why I, as a clinical psychologist by training, do the work that I do. We also know that caregivers are at risk for their own physical and medical problems, including cardiovascular disease, poor immune functioning, fatigue and sleep difficulties, and even higher rates of mortality. Without support, caregivers represent the next generation of your patients with chronic and life-limiting illnesses. There's a financial component to burden I've already touched on, the social component, primarily that isolation, as well as a spiritual and existential component. The spiritual component often manifests as a crisis of faith. Caregivers might say, why me? Why us? Why now? One's belief system may get challenged. If there's a God, if there's a higher power, then this would not have happened. Or I thought the world was a safe place, but it's not. The existential distress is the distress that we all experience when we realize that we are human, we are mortal, and we and all who we love will all eventually die. And this is something that every caregiver experiences, though certainly is more prominent for caregivers of patients living with more advanced diseases or more severe illnesses, though it's prominent, it's something that's present for all caregivers. And we know now from a growing body of literature, very much drives psychopathology in caregivers. My colleague Nicholas Odom highlighted during the pandemic some drivers of continued and increased distress in cancer caregivers. I want to share these with you and say, I don't think these are limited to cancer caregivers. These are drivers of distress among all caregivers. And I'll start by saying that there are an increasing number of patients who live with advanced disease. Our therapeutic technologies are improving and patients are living longer, and that is a wonderful thing. But that also means that caregivers' responsibilities are enduring for longer and longer periods. And second, there's an increasing number of patients living with significant comorbidities. It's very rare to meet a patient with only one diagnosis. You are all the experts in that. It's rare to have a patient just with a dementia diagnosis. But often with each additional comorbidity leads to additional responsibilities on caregivers' shoulders. Third, there's a significant push to outpatient and homebound care that depends on caregivers. And certainly while the pandemic propelled this was occurring long before COVID came into our world. I always like to share an anecdote from my own fellowship years. When I was at Memorial Sloan Kettering Cancer Center, this was early on in 2010. And I had been given a protocol to review from the IRB, and this was a protocol from the bone marrow transplant service. And at the time, they were piloting their very novel outpatient and homebound transplant protocol, which meant that a patient would get a stem cell transplantation and then they would go home, which was a wonderful thing because they didn't have to stay isolated in the hospital. But what was so striking for me as I read through this consent form is it said that in order for a patient to qualify for the transplant, they needed to have a caregiver available 24/7 for at least 1 month, and ideally up through the first 100 days post-transplant. And I thought to myself, what an incredible ask. And if we are asking caregivers to shoulder these responsibilities, then we certainly need to do something to support these very caregivers. What we are asking caregivers to do at home, the medical care, is complex. It's not just taking vital signs. It's not just giving medications. It's navigating PICC lines and catheters and wound care. Tasks once assumed only by all of you, only by the trained healthcare professionals. It also needs to be noted that in many cases, especially in the context of home hospice, that there is an increased period of incapacity in patients at home. Many times in the context of hospice care, patients live longer. And this is a period when the responsibilities on caregivers' shoulders are vast. The care responsibilities are vast. And they happen at the same time as caregivers are engaging in and feeling anticipatory grief. And so this is a very complicated period for caregivers. And I should note that, first of all, dying at home is not the right choice for every family. But even for those families where it is the right choice, and even in those circumstances when the death is peaceful, it needs to be acknowledged that those deaths ultimately, for many caregivers, are very traumatic. Of course, there's cost associated with care provided at home. I'm not going to drive that one home more. And an increasing number of caregivers are providing care from a distance, which leads to its own complexity. When distress is left untreated, a caregiver enters the role, their loved one is first diagnosed, whether it is advanced cancer, whether it is dementia, whether it's ALS. If there is distress present at that diagnosis and there is no support, that distress will increase exponentially across the caregiving trajectory. This is why early intervention is so important. There are, however, also particular points along this continuum in which caregivers are at unique risk for distress. And the latter two categories are, I'm sure, of no surprise to anyone today as patients transition to hospice care and caregivers into bereavement. It's obviously a very difficult time. But I want to highlight for all of you survivorship. This is a period, for example, in cancer care, when a patient's told there's no evidence of disease, you're not going to come back for treatment. It could be, for example, in the setting of Lewy body disease, a patient being on the right treatment regimen and no longer having rapid hallucinations. The point is that what we see in patients in survivorship is a reduction in distress and an improvement in quality of life. Many patients say they are returning to their quote unquote new normal. We paradoxically see the opposite experience in caregivers, a very significant spike in distress in caregivers and survivorship. And this is likely because this is the first moment when caregivers take an exhale. When their loved one was first diagnosed and they're going for first and third and fifth opinions, those caregivers are in flight or fight mode. But when they take that exhale, when they know their loved one is okay and they take a breath, there's a rushing in of all the negative emotions they were once avoiding during the initial phases of their loved one's diagnosis and treatment. And this is why it is so critical for all of you, if and when you are discharging families to the community, to ask caregivers how they are doing. Because survivorship is the same moment when families become disconnected from the healthcare team. And so I strongly encourage all of you to consider in those moments making a point to ask caregivers how they are doing and how you all can support them better. So I'm a clinical psychologist by training. I came to this work via my fellowship in psycho-oncology at Memorial Sloan Kettering Cancer Center, the field that unites cancer care and mental health. And in my first year of fellowship, I was working primarily with patients with advanced, life-limiting cancers at the end of their lives. And what was so striking to me as I sat with those patients and heard narrative after narrative was, as opposed to their focusing on their own mortality, they were focused on their parents and partners and children and siblings and friends. The individuals left in the waiting rooms and left at home. The individuals who they identified as the linchpin of their care and who would be most deeply impacted by their eventual deaths. I realized back then, this was 2010, this was long before the pandemic, that cancer care specifically, but healthcare more broadly, was increasingly relying on family caregivers to shoulder significant responsibilities without actually providing them with training or education. And despite the fact that the scientific literature had already very well documented distress in caregivers, had already documented that phrase caregiver burden again and again and again, there were no targeted support services for caregivers in any cancer center or healthcare system in the country. And so a year later, I sought to change that. I founded the Caregivers Clinic at Sloan Kettering, whose mission is to assure that no caregiver experiencing significant distress as a result of their critical role goes unidentified and deprived of necessary psychosocial services. The clinic provides care to caregivers of patients with all sites and stages of cancer, from diagnosis through bereavement. One of the critical steps I took that I want to keep on all of your radars when I began the clinic is I advocated that caregivers would become patients of the healthcare system with their own medical record and their own medical record number. I did this because without their own medical record, caregivers' privacy and confidentiality are challenged. And there comes the question of who is the patient. For example, I took care of my dad for nearly a decade. If my data had been documented in my dad's medical record, it would not be clear whether the patient was Allison Applebaum or Stan Applebaum. But if I have my own medical record, of course, that's super clear. And importantly, from the administration's perspective, having a medical record in place for caregivers allows us as a healthcare system to have an ethical mechanism to bill for services. There's many reasons why caregivers have come to Sloan Kettering for support and why they come to caregiver support more generally. And I want to highlight for these four for all of you. These are all things for you to keep on your radar as you interact and interface with caregivers in your own practices. The first being anxiety management. So if there's one commonality among every caregiver, regardless of the illness, the diagnosis, the prognosis of their patient, it is the difficulty they have with sitting with uncertainty, with not knowing what the next year or month or week or day or even the next hour may bring, and that can be maddening. So we certainly help caregivers to sit with that uncertainty and manage their anxiety. Second, what was so striking to me when I began this work is how many caregivers within the first few months would come to me and say, Dr. Applebaum, I have no idea how to speak with the oncologist. Or, am I even allowed to speak with the oncologist? Or, I want to talk to my husband about the future, but he gets angry every time I try to bring this up. What do I do? And it was very clear to me that many caregivers were coming in with a need for communication skills building, which is something I'm going to turn back to later on. Caregiving never happens in a vacuum, so we certainly help caregivers to balance their multiple responsibilities, as well as to address that existential distress. For example, young adults who've come to see me whose husbands or spouses or boyfriends or girlfriends were diagnosed with advanced cancer and say to me, I want to be fully present for him right now, but I also need to plan for a future in which he's no longer going to be here. That's certainly a situation in which existential distress arises. During the pandemic, my colleague and I conducted a study where we evaluated the availability of support programs for caregivers within cancer centers. And we defined support as ranging from anything like a comprehensive caregivers clinic like the one I founded to simply giving caregivers information about what they can find in the community for support. And among the 238 cancer centers we interviewed, 75% said they absolutely had a program, but perhaps not surprisingly, the most common program they had was simply giving information or referral to the community. So if we turn that around, that means a quarter of these cancer centers didn't even have that, which is certainly a problem. And when we asked about barriers to having actual support for caregivers, the number one barrier we heard was questions about the financial sustainability of a support program. Having a medical record in place for caregivers actually addresses that concern. I want to highlight for you my goal really moving forward, one of my goals, and especially now on faculty here at Mount Sinai and leading the new Stephen S. Albaum Family Center for Caregiving, is to help disseminate this model of care, to ensure that all cancer centers and all healthcare systems more broadly have caregiver support. And to do this, I started by collaborating with the American Cancer Society. This toolkit is available on the ACS website. It's open and free of charge, and it really is a Cliff Notes version to all the steps that I took to establish the Caregivers Clinic at Sloan Kettering. And on the website, there are also a series of webinars that you can listen to that can walk you through this. And I share this not because I think all of you, or maybe even any of you listening, are going to go start caregiver support programs, though I really hope one of you will. But I do believe that I am speaking to the next generation of leaders in healthcare, which means that many of you are going to start programs. The 10 steps that I outline in this toolkit are 10 steps that any of us should be taking should we want to start a program, whether it's to support patients or caregivers or anything else within the healthcare system. So I encourage you to use it as a resource. I also want to say that we were just awarded funding by the NIH to conduct training within 200 cancer centers in the next 5 years to develop caregiver support programs. So hopefully this model of care is going to actually get disseminated. So why is disseminating caregiver support so critical? I want to show you, this is just a snapshot of the number of randomized controlled trials, RCTs, that are looking at psychosocial interventions for family caregivers. And what I want to highlight for you is that between 2016 and 2020, there were 44 RCTs focused on psychosocial outcomes for caregivers. Now, in 2024 alone, and this was not done in the most scientific fashion, I admit, this was me going through PubMed one night last year or earlier this year, there have been at least 36 randomized controlled trials focused on psychosocial interventions for cancer caregivers, which means that the state of the science is moving very, very quickly. But if we do not have infrastructure on the ground, to deliver these interventions, then they're ultimately just going to sit on the shelf and not get into the hands of caregivers who need them most. I want to highlight 3 of the interventions that I've worked on with the hope that you can take from these some tools and skills to bring to the caregivers with whom you might be interacting. As you can see, my research spans the continuum from a patient's diagnosis through bereavement for caregivers. And what I want to acknowledge, the big takeaways from my research is that, number one, there is no one size fits all for care. The needs of caregivers shift and change across the caregiving trajectory, and we need to address these needs differently at different time points. Number 2, as a researcher, I never want to reinvent the wheel. We know, for example, cognitive behavioral therapy, it works. It's a gold standard treatment for anxiety and depression, and by the way, it works well in caregivers. So we don't need to create a new CBT intervention, but we do need to figure out how to make it feasible and acceptable for caregivers at particular moments, like, for example, when a patient is getting discharged from the hospital. So I want to start by talking about intervening with caregivers early on when they step into the caregiving role. And I want to start by saying that simply identifying caregivers is itself an intervention. Many individuals will say to you, well, I'm the daughter, right? Or I'm the spouse. I'm just doing what I said I would do when I married this person, right? That many don't necessarily identify as a caregiver, but helping them to see that actually what they are doing as caregiving is actually very powerful and very validating. We have in this country what's called the Caregiver Advise, Record, Enable Act. I can't see your faces, so I can't ask the question, how many of you have heard of this? The CARE Act is currently passed in 45 states and territories and includes the following 3 provisions. It says that hospitals need to document the name and contact information of caregivers in medical records. It says that hospitals need to let those caregivers know when patients are going to be transferred or discharged. And number 3, very importantly, hospitals need to let those caregivers give caregivers training and education so that they know how to take care of their care partners at home. Now, even in states where the CARE Act is passed, even in New York State, it's not consistently implemented. And that is in part because of understaffing and diffusion of responsibility. But what I want to highlight for all of us today is the fact that if we are being asked to document, if we are being required to document caregiver information, then that is the perfect moment. We've identified the caregiver. Let's take it a step further and let's screen them for distress. Let's ask them how they're doing and let's triage them to appropriate support. And that is the focus of the first study I want to share with you. And I'm going to start by sharing with you the conclusion, the punchline, and that is that distress screening is a very powerful intervention for caregivers. And by that I mean, simply asking caregivers how they're doing is a very powerful intervention. Again, I can't ask you who's familiar with a distress thermometer. This is one of the most widely used tools within the setting of oncology care. It's a simple visual analog scale, and it says to rate your distress. In thinking about what tool I wanted to use with caregivers, I didn't think that this was going to be the most sensitive. Again, for example, if you asked me to complete this distress thermometer half an hour ago, and then I take it right now, and then I take it in a half an hour when I'm done giving this talk, my distress level is probably going to go down. So how meaningful is that tool? So for this study, we used a measure from the cancer support community. It's called the Cancer Support Source Caregiver. It's comprehensive. It evaluates all of these areas and provides for us anxiety and depression risk scores. And what's most exciting to me about this tool is it allows us to build into the back end information about referrals specific to the institution. So for example, I did this study at Sloan Kettering. If a caregiver were to hit submit and they complete the form and they had indicated concerns about paying for their medication or putting food on the table, when they hit submit, they would immediately get emailed information about patient financial services at Sloan Kettering. And so not only is it a screening tool, but it's also a triage and referral tool. And so I wanted to evaluate whether or not simply giving caregivers this tool and checking in with them about their screening would have any impact on their emotional well-being. We randomized 150 caregivers, 75 got the screening and a phone call a few days later. And by the way, that phone call was an average 2 minutes long. And basically it was just saying, do you have any questions about the screening? And can we help you get connected to referral resources? The other 75 caregivers got what's called enhanced usual care. We gave them physical copies, a list of all of the resources available to them within Sloan Kettering. This is a repeat. I'm not going to go through it. Our caregivers were predominantly female, white, non-Hispanic, high SES, highly educated. This is a typical Sloan Kettering family. And the majority of these caregivers were recruited from the Josie Robertson Surgical Center, which is an outpatient surgical center where we conduct diagnostic procedures like lumpectomies and prostatectomies. So it's not surprising that the majority of these caregivers were new to the role. They had been in the role for less than 4 months and provided care for less than 4 hours a day, though there were a certain percentage we recruited from the main hospital who actually were in the role for over 2 years. We asked about their baseline problems. What were they challenged with? And most commonly, the physical problem reported was, I feel too tired to do the things I want to do or need to do. The most common logistic problem reported was, I'm having trouble balancing caregiving with everything else. The most common emotional problem was worrying about the future and what lies ahead. And the most common patient-specific problem was that I'm concerned about my loved one's cancer progressing. None of these are surprising. What we found, we followed caregivers for 3 months and then 6 months. At 6 months, those caregivers who went through the screening protocol reported significant improvements in emotional well-being. What's really important is that this was in the absence of any change in psychosocial service use, meaning those caregivers who got the screening did not necessarily come to the caregiver's clinic. In fact, I think only 2 did. So I was wondering what was going on here, and the qualitative data really told the story. So I always like to complement the quantitative, the measures, the patient-reported outcome measures, to complement those with some interviews. One caregiver said the notion that somebody cares, even if it's just the hospital, about how you're doing is really powerful. And that's probably what I took away from it the most. Another said, I don't think I need support right now, but it's good to know it's here in case I do in the future. Across interviews, caregivers said to us they felt seen and heard and valued and validated as a result of the screening. Simply asking caregivers how they are doing is a powerful intervention. Now, I know that many of you may not be in the position to use a screening tool like the Cancer Support Source Caregiver, and I know that many of you may not be conducting research, but I cannot overemphasize the power of you taking the time to turn to the caregiver in the consult room and ask them how they are doing, and then hopefully following up and helping them to find resources and referrals. And if they're here at Mount Sinai, we now have our new Elbaum Center within Geriatrics and Palliative Medicine specifically to support them. You're taking the time to ask the question, how are you? 3 simple words. For almost every caregiver, it has the potential to mean the difference between life and quality of life. And for a small subset of caregivers, it has the potential to mean the difference between life and death. I am actually going to skip over. I had wanted to present 3 studies to you. I'm aware of time, so I'm going to skip over one of the 2 studies that we are looking at in terms of supporting caregivers towards the patient's end of life of meaning-centered psychotherapy. Please do feel free to email me if you're interested in learning about meaning-centered psychotherapy. I would love to speak to you about it. What I want to actually spend time talking about is the communication training for caregivers that I've worked on. This article was published, I believe, in 2024 in the Journal of Psychosocial Oncology. Because this is an area where I think all of you play such an instrumental role. So healthcare communication is one of the most critical responsibilities that family caregivers shoulder, whether or not they step into the role of healthcare proxy or surrogate decision maker, but of course, particularly for those caregivers who do. And engaging in healthcare communication is challenging. It's difficult to engage in these discussions with care partners, with loved ones, because caregivers don't want to upset them. They want to maintain hope. There's a lot of magical thinking. If I talk about the future, if I talk about death, then death will happen sooner. And of course, these conversations don't happen in a vacuum, but they're superimposed upon family dynamics. And oftentimes what patients and caregivers understand about prognosis is different. And it needs to be said, caregivers have difficulty talking to all of you. Now, I should say not all of you, because you all are going to be perfectly trained in communication skills, but historically, caregivers have difficulty communicating with healthcare professionals. Number one, many healthcare professionals, not you all, don't initiate conversations with caregivers and are not initiating conversations about goals of care. Many don't know the right words to use. And it can be difficult for all of you when a patient and caregiver are on a different page. And I shared with you early on how many caregivers who came to our clinic shared concerns about communication. And so I really realized this was an area that needed something more. And so I wanted to develop a communication skills training program that would assist caregivers in the following 2 goals: to develop a clear understanding of the patient's values related to how they would like to live at the end of life, including what type of care they would want to receive, and to develop an accurate and shared understanding of the patient's prognosis. And we did this through teaching the following 6 communication skills. These are part of the Sloan Kettering Communication Skills Training Program that is done with healthcare professionals. And I thought, let's adapt this for family caregivers. And the skills we taught were agenda setting, working towards a shared understanding of your care partner's goals of care and end-of-life experience, learning to be empathic in responding to emotion, establishing mutual consent with a care partner regarding their goals of care and the conversation with the doctor, working towards a shared understanding of their prognosis, and learning to discuss goals of care in a straightforward manner. These are the 6 strategies we taught in our training. And we did a study to evaluate the feasibility, the acceptability, and the preliminary effects of a 2-hour training to teach these 6 skills to caregivers of patients with recurrent malignant gliomas. Before the training, we asked caregivers to tell us, what are your greatest concerns? For example, one caregiver, or actually many, would say, my loved one gets angry at me every time I open this topic. And so the training, which involved actors who played patients and loved ones, would play the angry husband, for example. The training had a half-hour lecture and then an hour and a half of role plays to help bring those strategies to life. And at the end, we had our caregivers set what we call SMART goals, specific, measurable, attainable, realistic, and time-bound, about what they want to do in terms of communication. I'm just going to rush through the slide. What I want to show you are this is a not great way to ask a question for a caregiver.
How much time does he have left, Dr. Klein?
Right, no one has a crystal ball. So we teach caregivers to ask this type of question.
Dr. Klein, could we talk about David's illness today?
Of course. What specifically would you like to talk about?
Well, if this clinical trial stops working, are there other treatment options available? And if not, what will David's quality of life be like?
So in the communication skills training, these are the skills that I want to illustrate the skills that we teach to caregivers. And these are skills, by the way, that each of you in this room can actually very easily teach to caregivers.
I'd really love for us to discuss your illness. When we met with Dr. Klein, he asked me if you had designated me as your healthcare proxy. And after the visit, I realized it's important that we talk about that before we complete the form. Would that be okay?
Sure, I guess.
I know this is scary. It's really scary for me, too. That's why it's important that we talk about these things now, so I'll be able to be your healthcare proxy and you can get that care that you want.
What specifically do you want to discuss?
I would love for us to talk about what to expect as we move forward with this clinical trial and what our response should be if it works and if it doesn't. And of course, if there are any questions that you might have, we'll make sure to cover them as well.
All right, for time's sake, I'm just going to somewhat rush through the study. What I want to really highlight for you is within those 2 hours, confidence in communication improved significantly, both in terms of communicating with care partners and communicating with healthcare professionals. And what was really striking to me is after going through this training, those who got the training down the line a few months later had significant reductions in depression, anxiety, distress, and improvements in preparedness for death. And this is really striking that just this 2-hour training and encouraging caregivers to set their goals about communication led to these outcomes. This means that anything that you can do to encourage caregivers to engage in these conversations, to teach them, for example, to set an agenda, put out on the table what it is they want to talk about and why, encourage them to have open conversations with their care partners at home so that they can get on the same page and have what we call that consent conversation so that they are both on the same page when they come to speak with you. This is something that you can do to coach caregivers. And these communication skills down the line can dramatically improve communication patterns and ultimately end-of-life care and caregivers' experiences into bereavement. I'm just going to rush through this. So I want to just say, for me, my future directions are very simple. My work is that I really hope that the documentation of caregiver data becomes a standard of care, that every caregiver will get a caregiver medical record, that every hospital system in this country will have caregiver support, And I also think that caregiver status is something we can start to think about within the setting of primary care. Certainly, each one of us should be going every year for annual exams and with our PCPs, and hopefully they ask us how we're doing. And the more we can do to talk about our caregiving status, the better able we'll be to track the public health consequences. I just want to end by saying that each one of you in this room, even though you may not be someone who identifies as someone who's going to focus on caregivers in your practice, you all on the front line have the capacity and the opportunity to intervene with caregivers. And I hope moving forward, each one of you will consider that caregiver in the room with you your best friend. They are likely the best source of data. They have the best understanding of how patients are doing at home. They have the most realistic understanding of those patients' day-to-day functioning and their health-related behaviors. And so I strongly encourage each one of you to invite those caregivers into your conversations, to treat them like colleagues, members of the healthcare team, and to help them to get support when they need it. All right, thank you so much. I'm going to stop sharing my slides and hopefully we'll have some time for questions.
Yeah, thank you so much. That's a really important topic that, as you're saying, kind of oftentimes gets overlooked, I think. We do have a few questions in the chat. I think the first one is, how can healthcare teams better identify caregivers who are struggling before they reach a crisis point?
Early intervention is always better. So number one, I think we can do a much better job. I think we are required to document the caregiver in the medical record of a patient. So I think at that point of a patient's admission is when we should be asking caregivers how they're doing. And let's be honest, I think you all know this. A lot of caregivers will say to you in front of the patient, "I'm doing fine, everything's great." But anything you can do to speak one-on-one privately with that caregiver early on is going to be probably the best bet in terms of getting an honest answer. And I think ultimately, even if they're early on, there's probably a lot of distress there that you can help to address.
Makes sense. We also have a question. Dr. Applebaum, what are best practices for supporting caregivers who are enmeshed with their loved one, especially late in course when making end-of-life decisions or going through the dying process?
Oh my gosh, this is such a good question. It's such a hard question because all of this occurs in a context of pre-existing family dynamics. And so when we think about enmeshment and we think about decades-long, 50-year relationships, 7-year-long relationships, it's so very complicated. I will say again, this is why earlier is better. These are situations where if a patient still has capacity, I think one of the most powerful things to do is to, I hate to say moderate, but moderate conversations with a patient and caregiver together, and to ask the patient, what are your goals for yourself, meaning your care, and also what are your goals for your loved one, meaning the caregiver, and actually to ask the caregiver the same question. And doing so oftentimes can allow for folks to take a zoom out lens. Ultimately, especially with units who are super enmeshed, we find a network of silence where each party is wanting to protect the other one and is purposely not talking about death, is not talking about the worst case scenario. What we find, and this is borne out in the literature, it's not just my clinical experience, is the more we invite that elephant into the room and help dyads to do this, their distress is actually going to go down. So anything you can do to help navigate that conversation with them, and really frame it as a family dialogue about what is most important to you, meaning to the patient, and also what is most important to the caregiver, and what are your goals for each other. The patient who's dying likely has very important goals to share about what they want for that caregiver.
Thank you. I think we have one more question that I'd just like to ask. I think you've answered this a little bit, but I think it's talking about a specific moment. It's what strategies do you recommend for improving communication between healthcare providers and caregivers? I think particularly, though, during transitions of care.
Well, number one, these conversations often happen in a very rushed and hurried way, and often at a time when caregivers don't have the bandwidth to have these conversations. So one thing we have found that's really effective, and I'll talk about, like, for example, the discharge from the hospital. That is hands down one of the most stressful times for caregivers. That's not a great time for caregivers to be having intense conversations. If it's possible for you to do a follow-up phone call a day after the discharge from the hospital or 2 days later and find a time to speak with the caregiver, that actually is going to help the communication. Oftentimes just considering the set and setting can make all the difference.
That makes sense. That makes a lot of sense. Thank you so much for your time. We really appreciate it. Very important topic.
Of course, my pleasure. Good luck for everyone.
Thanks. For everyone else, that is the end of day 3. Tomorrow will be our last day, and it just like the other days, we'll start back up at 8:55, and then at 9 a.m. we'll have Doctors Ruth Spinner and Jeffrey Farber discussing clinical quality in the nursing home. Thanks so much. I hope you guys have a good day.